Hey, so this is a H&P on a patient that I saw during clinicals. So this is a 53-year-old female who subsequently was admitted to ICU, but she presented to the emergency department with the chief complaint of the worst headache of her life. She reported that she had recently had an abdominal mesh procedure 2 weeks prior, had had no problems regarding that. She reported that she had been having frequent headaches for the last 6 months that had been becoming progressively worse. She reported that she had been seen by her primary care doctor, who had prescribed her Fioricet. He had not done any imaging or anything. She reported that over the last month, she's been having noted left-sided facial weakness that was worse throughout the day, towards the end of the day. As well, she had been having increased forgetfulness. This morning, she reported that she woke up with nausea, vomiting, and had the worst headache of her life. She then presented to the ED for further evaluation. Her past medical history was only contributory for hypothyroidism. Her only surgical history was this abdominal mesh procedure and removal. She had allergies to Bactrim, no pertinent family history relevant to any sort of neurologic conditions, stroke, or cancer. She denied smoking, alcohol, lived with her family at home, had 3 children. On physical exam, vitals were unremarkable. Her temperature was 99.1, slightly tachycardic, pulse was 110, normal tensive blood pressure. Head was normal, ear, nose, and throat unremarkable. Neck was supple, no JVD distensions. Lungs clear, no wheezing, no rales. Heart normal rate and rhythm. Abdomen was soft, non-tender. Lymph nodes, particularly to the cervical and neck, were unremarkable, normal. Skin was normal and intact. Neurologically, she did have decreased grip strength to the left arm. She had no gross focal or neurologic deficit. She was oriented ×3. Cranial nerves were intact. Laboratory data that was done. She did have white blood count of only 9.2, normal hemoglobin. Creatinine was 0.7. Liver enzymes were normal. Her labs also were mostly unremarkable. An MRI was done because she had been complaining of this severe headache with left-sided facial numbness and some hemiparesis. So the MRI actually in the ED indicated that she had a large 4.5 by 4.5 right frontal hypervascular mass with noted vasogenic edema present and some midline shift of approximately 8 millimeters in the frontal region of the brain. So, though at this point in the ED, when the patient would present for the worst headache of her life, there would be really 3 pertinent differentials that you would need to rule out. Particularly, of course, a do not misdiagnosis would be something like a CVA or TIA. Her pertinent positives for a CVA would be the forgetfulness, left-sided weakness, significant to the upper extremity, of course, could be in the lower extremity, but pertinent positives to rule out a CVA. Pertinent negatives were the timing. She did have a slow onset of these symptoms, though today it was insidious onset. Number 2, second differential would be a temporal arteritis. Pertinent positives, she complained of a throbbing headache. She did have tenderness on palpation to her face and temporal region. Pertinent negatives really would be the onset, hence the slow onset, and her forgetfulness. And then thirdly, her symptoms would lead you to want to rule out some sort of brain tumor or mass. Pertinent positives for that would be, of course, the slow onset of headache with increased forgetfulness and progressive weakness with neurologic changes to her extremity. Pertinent negatives would be the tenderness to her face. So in this patient, her assessment plan would include a brain mass. Of course, at this point, it was unknown what it was. So a patient would be admitted to neurosurgical ICU. The neurosurgeon consulted frequent neurochecks Due to the vasogenic edema, you would place patient on oral dexamethasone, which is typically 4 to 6 milligrams Q8 hours for the vasogenic edema, ordering a stat MRI and MRI with contrast to further delineate the tumor. PTO-TST, seizure precautions, clearly because she did have midline shift and with a large mass, you'd be concerned of seizure. Place patient on seizure precautions, initiate Keppra. You could initiate a loading dose, although she didn't have active seizures. Start her on Keppra 500 PO or IV BID and a neuro consult. Also anticipatory that this patient would have some sort of procedure. Subsequently, this lady did. She was found to have a meningioma and had a resection of the mass. But you would order stat coags and perhaps prepare the patient for a surgical procedure. The reason that she was admitted to the ICU and you would consider is the patient's status. This patient had severe headache and some neurologic change. So you would want to watch her very closely regarding her airway, breathing, circulation, and neurologic status. Two, regarding her headache, putting PRN, Fioricet and such, and go from there. Thank you.